Hi, in this video from Suvi Eye Hospital, Kota, Rajasthan, we describe phacoemulsification in patients with kyphosis and other structural problems or those who are otherwise unable to lie flat and how to achieve a balance between positioning and surgery for these patients. This was a 56 years old gentleman who had cataract for the last 1 year and had significant visual problems, but he also had severe kyphosis which made him unable to lie completely flat on an operating theatre table or to even sit up or walk up straight. He consulted many ophthalmologists, however they were uncomfortable with the idea of operating on him because of this severe limitation. And when he presented to us, we did a literature search to find out as to what was the best way to perform a surgery on these cases. There were a few reports where patients with postural disorders had been made to sit up on operating theatre tables and the microscopes had been tilted with patients made comfortable, and the surgeon performed the surgery either straddling by the patient's side, or in one case, in one article, it was even described that the surgeon had performed the surgery sitting face to face with the patient through an inferior or inferiotemporal incision. However, we could not find any of these methods to be practically useful for this particular patient, so it was decided that the surgeon would operate the case while standing. This, of course, was quite challenging. This is the patient who was propped up on the operating theatre table with lots of pillows so that he was virtually sitting up straight. The surgeon was standing and performed the surgery through the temporal side. The other steps were as for any other routine phacoemulsification. A capsulorhexis was done. This was a relatively soft nucleus, and so phacoemulsification was not a problem. However, we must remember that all these cases must be done by experienced surgeons, and the surgery should be performed quickly and efficiently, as many of these patients can become restless at any stage and do not remain cooperative. As you can see here, the phacoemulsification is progressing smoothly. The surgery is just like for any other phacoemulsification. However, we must remember that the bottle height needs to be adjusted according to the changed position of the patient head in these cases. This is the irrigation aspiration being performed, and as you can see, the surgery has been performed pretty well and there is no problem. Once the eye was clean, an AMO sensor IOL was implanted into the capsular bag. This is the IOL being placed carefully into the capsular bag. All the movements in these cases have to be gentle and quick, so that there is a tendency for these patients to move suddenly or to be restless and not very cooperative, and we have to avoid any jerky movements which may fuel further problems for the surgeon. And this is the sealing of incisions and injection of intracameral moxifloxacin or Vigamox into the anterior chamber as per our standard practice. On the first postoperative day, the unaided vision of this patient was 6/6 or 20/20, and he could read N6 with a near addition. The second case, which is a 55 years old lady who was unable to lie flat on the OT table because of severe obesity and other cardiopulmonary diseases which caused orthopnea. So the patient was made to sit on a simple plastic chair with her legs lying on another plastic chair, and a headrest was propped up on this chair with the help of pillows and cushions so that the patient was comfortably sitting up. The surgeon again adopted a standing position for surgery. The microscope was in the normal position and the surgery was performed as for any routine case. This was a topical phacoemulsification with multifocal IOL implantation. And most of these patients also have associated cardiopulmonary problems, so general anesthesia is generally not possible, and it is safest and easiest to do these cases under topical anesthesia only. Again, the phacoemulsification went well with direct chopping techniques, and then an irrigation aspiration was performed to clear the capsular bag, and an AMO Technis multifocal IOL was implanted into the capsular bag. Postoperatively, she gained a vision of 6/6 unaided and N5 for near, again unaided, and could read very well and see for distance also. So to summarize, For performing phacoemulsification in postural disorders, we need to adjust the patient position so that the surgeon is comfortable, and this can be done by using lots of pillows and cushions, adjusting the operating theatre table to make it in an inclined position, etc. However, if all of these are not possible because of the condition of the patient, it is the surgeon who needs to change his surgical position and sometimes needs to perform the surgery in a standing position. In these cases, it is well to remember that we should always do a mock drill before performing the actual surgery to ensure that the patient and the surgeon are both comfortable. The surgery should be done as quickly and efficiently as possible and must be performed only by very experienced surgeons, because these patients tend to become restless at any point of time. The bottle height needs to be adjusted according to the changed position of the patient head during the surgery. Since it is not possible to control both the phaco and the microscope foot pedals simultaneously during the surgery, we must adjust and tilt the microscope as required before the surgery and adjust it well so that minimal movements are needed during the surgery. And these cases should not be delayed too much to the point where they become ultra dense and it becomes difficult to operate on them under these changed positioning conditions. So to summarize, many of these patients who have difficulties in lying down on an operating theatre table for various reasons can be operated if the surgeon can perform the surgery while in a standing position. Thank you.